I created this graphic to help us weigh the factors that might go into play in deciding when to intervene on moderate ischemic MR during CABG surgery. There's a lot of factors, and it's not a black and white decision, but oftentimes it's a multidisciplinary discussion weighing all these factors and what might be best for the patient. We start by looking at patient factors. Can the patient tolerate risk of more cardiopulmonary bypass for potential MR reduction benefit? I help answer that question by looking at the age of the patient and patient comorbidities, where a younger age may favor lower risk for more bypass along with minimal comorbidities. Next step, I'll assess mitral valve severity. What is the clinical significance here? Is the MR significant enough that it just can't wait for future intervention or even not to be intervened upon at all? We'll assess this with TEE to see if it's mild or moderate, or is it moderate to severe, which may push us towards an intervention. Or looking at patient symptoms, if they have dyspnea on exertion as the primary driver of symptoms, even more so than angina, that may signal greater MR significance. The next step I'll look at is left ventricular viability. Is left ventricular dysfunction reversible? Can CABG improve left ventricular dysfunction and its associated MR? I'll assess this by looking at hypokinesis versus akinesis of walls. Is a wall thinned or does it thicken appropriately? And even cardiac MRI may indicate some of the answers here. Whereas large hibernating myocardium that is revascularized may result in greater improvement in MR as opposed to very scarred and akinetic myocardium. Again, the question here is if I perform the CABG, will the MR improve on its own? And a very scarred myocardium gives a lower likelihood of that. Another factor here is looking at the coronary circulation and potential revascularization impact. If the inferior and infralateral wall has viable tissue and there is a stenotic coronary vessel that can be bypassed to improve blood flow to the PDA, then there's a possibility of improving posterior medial papillary muscle dysfunction, LV dilation, and subsequent MR. It's important here to know the RCA and left circumflex distribution. Are they right or left dominant? To know which blood vessel supplying the PDA, and if it's possible that we can add blood flow to this region to improve papillary muscle dysfunction. Finally, the last step I'll look at is transcatheter edge-to-edge repair eligibility. This tells me, are there alternative options available or not? Whereas if there's not alternative options, I may be more inclined to operate on the valve then and there to avoid a redo surgery. Versus if you know the patient can have a mitral clip a few years down the road, you may be less inclined to operate on the valve then and there. I'm not going to get into the details of surgical strategies here, but it is important to note that if we have a viable left ventricle with reasonable function, a complete undersized annuloplasty ring may improve function and may be appropriate if we're revascularizing here as well. Whereas if we have a non-viable, akinetic, severe dysfunction or dilation of the LV, or even have a P3 tenting angle greater than 29 degrees, we may err on the side of mitral valve replacement surgery.